Okay, well, thank you all for joining our PGY2 Pain and Palliative Care webinar series for this week. Our presenter is Dr. Brittany Johnson, PGY2 at UF Health in Jacksonville, Florida, and she'll be giving us a little bit of background on interventional pain management. So I think that this will be a fascinating topic, and thank you, Dr. Johnson, for taking the time this morning to educate us.
Absolutely, and thanks everyone for having me. Right now I'm on my orthopedic surgery rotation, and I've come across several different cases of sort of interventional pain management techniques that I've observed working with the anesthesia team, but also just patients coming in with unique things that I hadn't seen before in the outpatient chronic pain management side, things like intrathecal pumps and TENS units and stimulators, things like that. So I just know, as pharmacists, we focus heavily on the medication piece, but I think it's important to have sort of a broad understanding of some of these other interventional methods. So today we're just going to briefly touch on radiation therapy, destruction of the nervous tissue as an option, spinal cord stimulators, neurolytic blocking agents, elastomeric pumps, and then we'll talk a little bit more in depth on intrathecal and epidural infusions because those tend to be a little bit more commonly seen. And then I just wanted to highlight a couple of pharmacological areas of interest as pharmacists, ways that we can intervene. And additionally, some of the things that have come up while I've been on this rotation, just kind of food for thought, and I'd love to get input from other institutions as well as far as what they're seeing. So when we look at what interventional pain management really is, it's sort of a subset of the pain management specialty that's really focused on, the same pain-related disorders that we do from a pharmacological management standpoint, but they utilize interventional techniques in managing this. So it can be useful in the acute setting with utilizing blocks and things like that, as well as outpatient for steroid injections, more chronic pain management. It's definitely going to be indicated more so with our pumps and nerve stimulators in those intractable pain cases that we are having difficulty managing with other therapies. So it can really be, interventional pain can be used in conjunction with other treatment modalities such as our pharmacological therapy or independently alone. But I just wanted to kind of give an outline of what this definition is according to ACEP, just so we're all on the same page. Now, when we look at the history of interventional pain management, really didn't start gaining a whole lot of recorded traction until almost the 1900s, where Tuffer did the first nerve block for pain management. And then Van Gaza in 1924 developed a diagnostic tool using nerve blocks to sort of try to understand a little bit more about the pain pathways as we understand them today. And then interventional pain management really didn't get coined as a real thing until like the late 90s. So as you can see, we've been developing slowly and progressing in this area. And then it wasn't until 1998 that the American Society of Interventional Pain Physicians was formed. And this is where a large body of the literature now comes from regarding interventional pain management for epidurals and blocks and things of that nature. They also contribute pretty significantly to the literature with regard to understanding more about pain perception and the pain pathways on a more molecular level. So I sort of trended this presentation going from the most invasive or less commonly utilized methods to more commonly utilized in the inpatient setting. So cutting or destruction of nervous tissue, it can be utilized for peripheral or central nervous system issues, but it's very rarely done because it's quite invasive, and it's typically only been utilized in patients with a shorter deemed lifespan. So for neurectomies, this involves cutting of the nerve in the dorsal root ganglion, which I'll show you a picture of in just a moment. And then, you have this underlying concern if you are going to proceed with this type of intervention, that you can have something called deafferentation, and this is where pain actually returns even more intensely following the surgical intervention, up to 6 to 9 months post-intervention. A cordotomy also is another method that you can utilize for destruction of the nervous tissue. This involves cutting into the spinothalamic tract. However, you have risks of neurological and cognitive side effects from this because we're dealing right in that spinothalamic tract where we have a lot of other important neuronal communication occurring. So I've just highlighted here the two areas that we're communicating about. So the dorsal column area, as well as the spinothalamic tract, which is highlighted in green there for you on the screen. Spinal cord stimulation can also be a technique utilized for patients, typically more so in your intractable individuals. It basically works similar to the TENS units that patients may put on their ears or the back, or in areas that they're trying to get a sort of a distraction stimulation occurring. So the way that this works is there's an electrical stimulation on the dorsal column of the spinal cord. You can put anywhere from 4 to 16 leads along the spinal column. The one downside to this, besides the fact that it's an invasive procedure for the placement of the leads, is that the batteries have to be surgically replaced every 2 to 5 years. So I've shown you here on the right, highlighted in the yellow box. This is an X-ray just showing electrode placement with the leads that are followed inside on the dorsal spinal column, and then following out is the lead wire, and there's an extension wire that leads to this pulse generator, which, as I said, unfortunately has to be changed out with the battery. Most practitioners are recommended to use fluoroscopy to guide placement of this, and the practitioner will leave the pulse generator, the actual unit, outside of the body at first to ensure that it's actually efficacious before we go and surgically implant something underneath the skin. Most patients that are going to respond well to this are going to be more of your neuropathic mediated or ischemic pain types. So in our chronic osteo patient, this may not be the most efficacious option. Now, radiation therapy is something that's also used predominantly for just tumor growth and development, stunting that. So utilization of low-dose radiation can be utilized. We have the proton beam here at UF Health, and then, of course, we also utilize standard radiation therapy to reduce overall pressure and size of the tumor. By exposing the tumor to radiation, you can also reduce some of those inflammatory markers that it's able to reduce with the cell turnover because you're shrinking. And then this relief that you're providing to the patient can last anywhere up to 4 months. Neurolytic blocks are also an interesting interventional method. So this is a deliberate blunting of the neuronal signaling, either through the application of chemicals or heat or cold. It's really thought that if we can sort of disrupt this membrane and cause degeneration of the nerve signaling, then we can interfere with the way that the nerve communicates in between each other. And creating that destruction allows for a temporary relief. However, as long as we allow continuation of the basal lamina there, and that's preserved, as you can see highlighted in yellow, then the fibers are able to regrow within the basal lamina and restore function of that nerve over time. So if the basal lamina becomes destroyed at some point in this neurolytic block process, then we can start running into issues with restorative function in those areas. Now, when looking at infusion options, so in intrathecal infusions, this is going to be medication delivery directly into the subarachnoid cavity. So you have your dura mater, your arachnoid matter, and then you have your subarachnoid cavity. So this is where the drug will be directly delivered. And commonly, opioids and choanalgesics will be used here. Baclofen is one of the common choanalgesics utilized. Something I didn't really know much about is this ziconotide. Sorry, I still have a hard time saying it. And that's actually comes from the shell of a snail, which is pretty interesting. And it can be utilized as an anxiolytic in an intrathecal pump as well. So clonidine with its alpha-2 activity and baclofen would be another adjuvant. Local anesthetics can also be used. Most commonly, you're going to see the bupivacaine utilized. Ropivacaine is thought to have some reduced cardio effects with the concerns for ventricular fibrillation. However, most institutions, I think from a cost, risk-benefit standpoint, are still utilizing bupivacaine. But that's an interesting point for conversation. If other institutions are doing it differently, we can discuss that at the end. And as I said, your common opiates, morphine, hydromorphone, fentanyl, and sufentanil can all be used at significantly reduced doses to what we would typically use IV or something of that nature, which I'll touch into in just a moment. So this provides analgesia to the patient with reduced side effects because we're going straight into the subarachnoid cavity. And it's typically going to be considered, again, for those more intractable cases. Now, something else to note with this is that these intrathecal infusions come with both a PCA option as well as just a continuous rate option. So in the patients that I have seen on the inpatient side with this, most of them are very knowledgeable about their pumps. It's similar to those individuals that you run into with a diabetes pump. They tend to be very familiar with what their dosing is and how frequently their well is filled and things of that nature. It is implanted just underneath the skin. So if you have a larger patient, physical exam is going to be really important, and asking some of those interview questions. I've actually come up on a case where we had a gentleman on a pump and we didn't identify it until several days later after he had already been on service because we missed that on the physical exam. So making sure we get a thorough interview for some of these patients that have had a significant history, it's something that I would add into your assessment, just asking those questions. So similar to the nerve stimulator, this is going to be implanted underneath the skin. So you see here, there's the receiver that controls the amount of medication being delivered. And the baclofen or hydromorphone, whatever the agent is, will be delivered into the well. And this will have to be reloaded, but conveniently it's located just underneath the skin. So physicians can re-administer or refill that well as necessary. The patient will then be in charge of an external controller if they have their own PCEA function. If not, the physician will turn the system onto the appropriate settings, and it will only be adjusted by the provider at the time that the patient comes in for refill or follow-up checkup. So similar to any of our like epidural interventions, it's going to be fed right through a catheter and deliver the medication right into the intrathecal space. So pretty unique and interesting way to deliver therapy to patients that have had chronic issues, especially those intractable individuals that were just not really managing very well with pharmacological therapy, PO agents, I should say. Now, for epidural infusions, these can be used in a wide variety of settings. You'll see them on nearly every OB-GYN patient that's delivering. Also, these can be used for patients receiving mastectomies, patients receiving Whipples, thoracotomies, anything of that nature. Typically would be intervened in the spinal column here. Now, both opioids and local anesthetics can be used. Again, commonly you'll see things like fentanyl being used as far as opioids are concerned. And then your local anesthetics typically will be bupivacaine. Like I said before, you can utilize ropivacaine as well. Based on the area of coverage, your strength may vary or the rate at which you run it may vary. But the main delivery system is going to be through the spine. So the physician, as you can see here in the picture bordered in blue, the physician will have the patient arch over, opening up the spinal column, and this allows for them to get in through those ligaments there and into the osseous space to allow for delivery of the catheter, which is highlighted in the yellow box. So once the catheter is placed, they'll screw on this glass syringe. Some physicians will use an air bubble. Other physicians will utilize normal saline. And when they're utilizing this, they're not injecting it into the patient. They're utilizing it for an air bubble technique. So if they feel that they're punctured into the epidural space appropriately, they'll sort of bounce back and forth this syringe and make sure that they don't find resistance with their air bubble. Once that's been verified, they'll give a small test dose of lidocaine and ensure that the patient doesn't have any arrhythmias that occur or any altered taste sensations, anything like that. Anything abnormal from the patient is what we'd be monitoring there. And assuming that placement is appropriate and the patient responds well, then the physician will go ahead and feed in the epidural catheter, which you can see highlighted in the green box here. Now, the epidural catheter, once it's fed in, is going to be typically wrapped around to the front chest area of the patient, and that will further connect over to this medication delivery system that you see here highlighted in the blue box. Now, at our institution, this can only be dose adjusted by our anesthesia team. However, I'm interested in hearing what other institutions are doing at their practice site. So any dose adjustment would be made by anesthesia as far as increasing the rate or even changing out the bag. We have to have approval for that from the nurse has to contact the anesthesiologist before that bag is changed out. I think we do that for just a higher level of security and safety for the patient, but I'm just interested to know what other institutions may be doing. So as you can see here, I put the dermatomes up, and I just wanted to use this to kind of depict the area of coverage that we would expect. So for example, let's say we were doing a T7 block with the epidural. So we would expect this to spread 4 levels above and 4 levels below. So pretty good thoracic and abdominal coverage there. If for some reason we didn't get full coverage, we could increase the rate. So we could say, if we're infusing the bupivacaine and fentanyl at, 4 mils, we could take it up to 6 mils. I've even seen them do 12 mils an hour to try to spread that coverage for blockage. Now, that is to say that this, there are pros and cons to doing that. So by increasing the rate, you may start to get sort of collateral blockage moving down into the legs. And that's one of the main benefits of the epidural in the first place, is that, most patients are able to ambulate with it. So just keep that in mind, like as you're increasing, you may start to spread into unintended areas and create block there. An ICE test can be utilized to get good parameters on your area of coverage in these individuals. So the physician will typically take ice and put it into a bag, touch it to the patient's hand and ask them, is this cold, yes or no? The patient will respond. And then they'll start, let's say at T11 and start moving their way up the abdomen, asking them, can you feel this? Is this cold? Yes or no? Is this cold? Yes or no? So providing that coverage on both sides gives you, sort of an objective understanding of how well your patient is blocked and what type of coverage that you're receiving from those individuals. Elastomeric pumps are sort of a neat invention. We utilize them pretty heavily on the orthopedic service for our total knee and ankle arthroplasties. These are convenient in that they deliver a continuous regulated flow of local anesthetic over typically 2 days or so, but it depends on what rate it's set at. And it allows portability and ambulation to the patient. So as you can see here, there's a little clip I use this picture from the on-Q pump, but there are several different types of elastomeric pumps available. But the on-Q pump, you can clip it to the patient. They can ambulate with their walker or cane, or participate in physical therapy. They even have little pouches like fanny packs that the patients can utilize, so that way they're ambulating quicker. And it also, the catheter provides flow of the local anesthetic directly to the wound site. So they're able to still have reduced systemic side effects, reduce opioid consumption. And, anecdotally, these have worked very well for the patients that I've worked with. And I think that, one thing to remember is that these can also be used in multiple sites. So if you have a patient that's getting 2 knee replacements, you can put one on each site. So that's kind of a convenient way to provide local analgesia and hopefully reduce opioid consumption. Steroid injection therapy is commonly utilized on the outpatient side, and it's typically utilized more so in those major joints. And the thought process behind it is that we can reduce inflammation and, still have minimal systemic absorption. The duration of efficacy, however, when reviewing the literature, I found to be highly variable across study designs and dosing and agents utilized. So, typically we tell these patients this will last several months, but for most of you that have worked in the outpatient clinic, I'm sure you've heard highly variable findings as far as overall efficacy. So that 4 to 6 week range becomes very gray area for most patients. And then there's also these longitudinal concerns for, continued use of steroids and the risk of osteoporosis. Steroid options, typically it's going to be the dexamethasone. However, triamcinolone or methylprednisolone can also be utilized for these patients. Now, because we are pharmacists, I just wanted to briefly touch on some of the pharmacological contemplations that may come up when you're running into utilizing intrathecal or epidural agents. And one of those is how to convert between, if you have a patient on an intrathecal pump, how are you going to discharge them out on something oral, or if they have an epidural in right now and you want to take the epidural out, how do I start them up on their oral regimen? And, when you're converting between the two, the dosing conversions, are complicated for most physicians just by doing PO to PO conversions. I spend a lot of my day helping them with that, much less, adding on this extra layer of icing with different routes of delivery. And unfortunately, the literature is very limited in providing how to go about doing this. So, in reviewing Dr. McPherson's book, as well as some of the literature that she cited throughout her chapter on this, the main take-home message is start low and go slow, just like we do with anything else. And this conversion that I provided here, with oral being 300 milligrams of morphine, parenteral being 100, epidural being 10, and intrathecal being 1, is really, probably weak evidence based at best, but it's the best thing that we have to go on, and I think it's commonly used clinically. However, you'll find in the literature and in what you read, these ratios will vary pretty widely, but this has been a commonly accepted clinical practice application. And then also I adopted this from Dr. McPherson's book on demystifying opioid conversion calculations as well, just showing the difference in epidural dosing versus intrathecal. You'll see there's significantly less being utilized in the intrathecal space because that's more direct to the CSF compared to the epidural space. You're going to get a faster onset of action with intrathecal utilization, but there's a lot more risk and concern about sterility and things of that nature that we have to be worried about. But duration of dose and efficacy is really not too significant between epidural and intrathecal utilization. So I think that's why we commonly see epidural utilized more so in a more frequent inpatient setting. And then these are just 2 agents that I wanted to bring up because they've been a point of conversation with my physicians. And I know ketamine isn't really it's not really that new to the block anymore, but it's kind of a hot and sexy topic. And then also liposomal bupivacaine, just because I dug in a little bit to the literature on this, because podiatry at our institution has a high level of interest in its utilization. And so, again, this is something that I think would be a great point of conversation following the presentation. So the utilization for ketamine and nerve blocks, there is literature out there to support the addition of ketamine in pectoral blocks, as well as some of the modified pectoral blocks that we're using, so that most commonly in like your mastectomy patients. And in utilizing ketamine in conjunction with the bupivacaine or your ropivacaine, really, you know, it's going to reduce your morphine equivalents by a small amount. So in this study, they found a 7 milligram of morphine reduction overall throughout the study period. However, the time to their first required analgesic dose was delayed by about 2 hours. The beauty of ketamine is that we can reduce morphine equivalent consumption and hopefully get patients mobile quicker and reduce their overall opioid demand at the same time without really increasing any of their side effects. Also, ketamine is much more friendly if we're dealing with, you know, our more morbidly obese patients, which we're seeing more and more of. If we utilize ketamine and try to be a little bit more opioid sparing, we reduce the risk of that post-operative hypoxia that can occur, especially in our OSA obese patients as well. So it's just something to consider adding to the table. I don't know if other institutions are implementing it. We've really just started considering it in our nerve blocks and things like that here at our institution. And then liposomal bupivacaine. I know it's been out for some time now, but it continues to be a controversial topic, mainly because of the, you know, cost prohibitive nature of it. It was originally FDA labeled for bunionectomy and hemorrhoidectomy indications. However, you know, the data has been expanded to looking more so at total hip and knee arthroplasty blocks, because, you know, that is a common area that we're utilizing nerve blocks in anyway. Now, some of the things that sort of make the liposomal bupivacaine formulation a little bit more attractive is that it has a higher Tmax and a longer duration of therapy compared to the, you know, 8 or 12 hours that we would expect with a regular bupivacaine nerve block. And it's shown in some literature in the total hip and knee arthroplasties to reduce length of stay from what I've read anywhere from 1 to 2 days. And patients do typically get more physical therapy in their hospital stay because they're able to participate in physical therapy sooner. However, when we look at the utilization of opiate demand, maybe in those initial few hours we see benefit, but overall during the length of stay with the patient, we're not seeing that consistent reduction in morphine equivalent consumption. So with regard to side effects, also the erythema that occurs, the cardiotoxicities, there's original thought that we may see a significantly, you know, reduced amount of that by utilizing liposomal. However, this hasn't shown to be really clinically relevant. And it's very cost prohibitive in that it, you know, costs significantly more. One of the papers I read said, we don't have it here at our institution, but one of the pieces of literature I read said that it goes up to 100 times the amount of bupivacaine alone. So when I looked at it on Lexicomp, it's around $350 for a vial. So, you know, the thing that you have to really say to yourself is, okay, if an inpatient stay costs $3,000 or $4,000 for a day on the unit, and you can reduce length of stay by a day in some of these patients, well, then that might be worth it. But I didn't see any of the cost effectiveness analysis assessing those parameters, unfortunately, to really consistently show that, because that's what, you know, that's kind of what my thought process was when evaluating the literature on that. So in conclusion, interventional pain management encompasses multiple treatment modalities, and ketamine may have a role in reducing opioid demand and time to first analgesic dose. Liposomal bupivacaine, there may be a limited role for it, but however, it still remains cost prohibitive. And whenever we're converting from intrathecal or epidural over to oral or oral to intrathecal, we need to make sure that we start low and go slow, because we don't have a well-supported body of literature to really be concrete in what we're converting to for our patients. So at this time, I'll take any questions that anyone might have or comments about what's being utilized or what you're seeing at other institutions.
Brittany, this is Chris. I'm curious with the slide that you showed, giving us some reference points around oral versus epidural, IV epidural. This one, do you feel like this is applicable to all of the opioids that we give? I don't know if you said that or not, but
yeah, I think it's going to be highly variable. And that's, kind of why I try to preface it, because, that's assuming that everything that we get, if we take fentanyl and convert it over into morphine equivalents, that first conversion was made on something well-founded. And even our opioid conversion tables that we utilize in general are not well substantiated in the literature. So I think that's, why I try to implore to be very, very conservative in starting off and give ample breakthrough if necessary. But you're right. I think that there's going to be variation among opioids and among delivery system, whether you're going from epidural to oral or, oral to parenteral. There's going to be variability depending on what agent you're using and what your patient type looks like as well.
I don't have a lot to do with intrathecal pumps in our area, and not many people are placing them around here any longer. But once in a while, we'll still get a patient that comes in that tells us that into the hospital that tells us that they do have an intrathecal pump, and usually they are unable to tell us very much, if anything, about what drugs are in there, what the dosages that they're getting are, whether it's even on or off. I mean, it's a mess. And I'm just wondering if, based on your experiences or what you're doing there, do you have any best practices for the rest of us of how to approach these patients when they might come into our institutions?
Sure. So that hasn't been my experience. We have a predominantly indigent population here. Most patients are not able to tell me, even what their PO opiate regimen is for the most part. But I guess maybe I've just had a stream of good luck with the intrathecal patients that I've seen. Most of them come in with their actual documentation that will tell me the last time that their well was filled, what their current rate is being run at, how often they can hit their PCA for an additional delivery, and what that dose is. And it also provides in the documentation their starting volume and their time of next refill. So I might have just been overly fortunate with those individuals that I've seen. But here at our institution, we actually have a best practice in place in that once a patient is identified to have an intrathecal pump, the pharmacist goes and speaks with the patient. We fill out documentation with the patient as far as who the provider is that's writing this intrathecal pump. We'll get the information. If the patient isn't able to provide it from us, we'll call the provider and then get that, what their current, if they have hydromorphone in there or what their current dose is, as well as, their last fill of their well, how frequently they can utilize the PCEA function. And then we put that into the medical record. So once we've gathered that information, we, as pharmacists, will write a note and document in the medical record. That way, most of these patients that are coming in are typically actually on my OMFS, the oral maxillofacial surgery team, is where I've seen the majority of them, interestingly. And so for those individuals, because that service often consults other services, we try to have something standardized in the medical record to allow, for them to communicate and everyone to be on the same page. If it's something that I identify in my pain assessment with the patient, then I'll, of course, contact the resident provider at that time to just make sure that they're aware. And that's, in the case that I mentioned where we had the patient in for several days before realizing they had an intrathecal pump, it was a patient that I came in and interviewed. And so I had to contact the provider at that time and fill out the appropriate documentation. But that's sort of how we have standardized it. We treat it kind of similar to like an at-home medication, and that we want to get all of the documentation on dose and make sure that everything is up to date and current with it.
Thank you.
Sure.
Everyone has the end of the semester sleepies, it looks like.
Yeah.
Any other questions out there?
That's okay. I don't blame them.
Brittany, this is James Ray. I wanted to ask for a point of clarification.
Sure. Hi, James. I see all of your posts. I feel like I'm meeting a famous person.
Oh, I have too much free time on my hands, I wanted to ask about your slide where you listed the agents that could be used for neuroaxial delivery.
Okay.
You had the opioids, and then you had clonidine and ziconotide underneath that.
Mm-hmm.
And you had them listed under a heading that says anxiolytic. I just wanted to clarify, did you actually mean anti-neuropathic?
Oh, yes. Thank you for that.
Okay.
Yes, thank you.
I thought that's maybe what you meant.
Yes, I'm sorry. Thank you for that. Yeah.
All right. Thank you.
Thank you.
Brittany, I just wanted to say that this was really an excellent presentation. This is like very high-level stuff for pharmacists because it really kind of takes us way out of our comfort zone to be dealing with some of this neuroanatomy, and especially some of this technology that for most of us, unless we kind of get pulled into it, we almost never see it. So
Right.
Thank you. This was an excellent presentation.
Oh, thank you very much. Yeah, I think it's important for us to at least have a general idea of these intervention types, just because I was so far outside of my comfort zone stepping in from a pharmacy background, and everyone, on the medical team talks about it like you just know, like it's common knowledge. So I'm glad that you found it helpful.
Well, if there's no other questions, I'll go ahead and bring this to a close, but I have to tell you, this has been one of the best interventional pain overviews that I've seen. I really thank you for your time on this.
Oh, yeah, sure. Thank you so much.
The recorded webinar that Dr. Johnson provided this morning, like the rest of them, will be available to the members of the Society of Palliative Care Pharmacists under the member portal. It can be reviewed as a recorded YouTube video. I hope that everybody has a wonderful holiday season. I don't think we have any other programs scheduled, but let me double check real quick. Let me look. We don't have anything scheduled on the 23rd or the 30th. I think probably what we'll do is take a couple weeks off and give everybody a chance to catch their breath. And then I'll see everybody back at the beginning of the year for more wonderful pain and palliative care education. So Thanks, guys, and happy holidays.